Hi, my name's Jackie Bowes. I'm a practice nurse at Wibsey Medical Centre, Fair Road, Bradford. I've been a nurse for over 25 years and I've worked in general practice for 15 years. I come across a lot of patients. I've known my patients quite well actually, and as a result of that you get to know people's personalities and how they are. And so often people come into surgery and you often know there's something wrong, and through talking to them and looking at their body and how they express themselves, you often find that people are depressed. So that's just a little bit about me, and like I say, I do quite a wide range of duties in the surgery. When they come into surgery, often, like I say, they can come in and they're not the usual selves. They can often not making eye contact with you. Their body, the way they express themselves through body image is different. They slump down, they're not looking at you. They might be answering you with yes and no answers and things like that. So often through interacting with people in the surgery, that's how I would identify somebody's got depression. Obviously, people in their home lives, the families may notice differences in how their family or friends are behaving. So they might not be wanting to socially interact with people, and they might wanting to be socially isolate themselves and not interact with society, and generally their mood's very low. They may be weepy, emotional, or they might express themselves in other ways with like anger and sort of unrealistic behaviour that's not realistic to that person. And often it's somebody's relative that'll actually come into the surgery and say, actually I'm worried about my mum. And there might be things that might trigger that off. Well, first and foremost, you have to sort of identify what type of depression they may have. And obviously there's different forms of depression. So when they come into surgery and I think that somebody has depression, then obviously we do a questionnaire to find out whether they've got depression. And it's called the Depression Screening PHQ-9 assessment. And it's a series of questions that we ask a patient, and then it has a number system, so there's a score to it. And so, for example, patients can have minimal depression with a score of 1 to 4, or they might have mild depression with a score below 10. 10 to 14, they might have moderate depression, and obviously a score of 15 to 19 is moderate to severe depression. And anybody with a score above 20 is severe depression. And there's different steps and processes that we go through in terms of deciding what treatment we're going to put patients on. So obviously with mild depression, it can be just a case of coming back a few times, discussing the problems with somebody, getting that patient to engage into doing, getting involved in self-help groups, changing the diet, doing a bit more exercise, because exercise has been shown to increase the serotonin levels, and that makes people feel good about themselves. So if everybody did exercise, we wouldn't have half of the depression we have in this country. Mild to moderate depression, it could be talking therapy, psychodynamic and cognitive and behavioural therapy, which they have to be referred into by a doctor. Counselling can certainly help with moderate to severe depression, but often you find that they need medication as well, antidepressants, as well as the counselling. Moderate to severe, like I say, is antidepressants. Sometimes they have to be referred for combined therapy, or they may need to be referred to the mental health team, psychologists, and we also have community mental health nurses that can help with those things. The NH Choice website does have a lot of helpful leaflets for patients. Exercise for depression, general anxiety disorder in adults, how you can treat that, low mood and depression, the ways in which people can sort of counteract that. It has a lot of information on clinical depression, living with clinical depression, and also information about what causes clinical depression. So there's a lot of information on the website that can help with that as well. And obviously signposting people to these cognitive behavioural therapy sessions. The thing with that is those sort of sessions across sort of Britain are probably a bit sparse because of funding and things like that. So some services in certain areas will be very good and some will be very poor. And the length of these sessions that patients have to go through can be as short as 6 weeks to 12 weeks. So what I'm trying to say with that is that the support and help that's available is a bit patchy across the country, and that's all down to where the funding and the provision of funding goes. Yes, they certainly can. Being able to relax and wind down, especially if they have a stressful job that causes them to be depressed, anxious, stressful. Exercise certainly helps with depression. Like I say, it increases serotonin levels, so it helps people feel good about themselves. It's important that patients are sleeping well, so they might need a short-term sleeping tablets, things like that. It's important that they seek advice, and that if they're smoking or they drink a lot of alcohol, that they need to take that into account, because obviously drinking a lot of alcohol can cause depression, and the more they drink, the more depressed that some people can become. And also, if they have been given medication, it's important that they take that medication, because a lot of antidepressants, they can take up to 2 to 4 weeks to actually start working and be effective. And if patients are not actually taking the treatment, then they're not going to get any benefit from it. If they're only attending, ad hoc to different sessions and not going to the full course of the sessions, then they're not going to get any benefit from that. So it's important to make sure that these patients are attending these appointments, that they're taking their medication, that they're getting followed up regularly, because often patients, like I say, if they're socially isolated or they're disengaging from society, they may not come to the doctors, and unless you sort of keep close tabs on patients that have got depression and are taking medication like that, then at least you can follow them up, even if it's just a phone call, if they don't want to come into surgery. So that's other ways that you can contact people, is through, telephoning them, doing home visits sometimes is beneficial in that situation as well. And obviously communicating with other members of the multidisciplinary team. Your GPs, your healthcare assistants often come across patients with depression, your health visitors, other health professionals that work in the community. So often, you have diabetic nurses going into patients' homes and things like that. So communicating with the multidisciplinary team is very important when dealing and managing with patients with depression. Well, there's lots of things. There's a lot of online agencies that they contact, like Samaritans. There's independent counsellors, where there's a full array of registered independent counsellors on the website. There's Mind Charity that they can contact. Women that have got postnatal depression, there's Samsara and Bliss, their support networks. Samaritans offer one-to-one counselling, so after they've initially engaged with somebody by the telephone or by going on the website, they offer counselling as well. Independent counsellors, sometimes you have to pay privately for those, and obviously if there's a financial implication, then that can be a difficult one. And Mind, the charity there, they don't just focus on depression, but they focus on all aspects of depression and mental health problems. The Samaritans look at a broader spectrum of things. It can be anything down to social deprivation. It can be all sorts of things. They don't just focus on people with depression. It's just people that are just not coping well in life. So they're the main things. And like I say, going to the GP, referring them on to different specialities like for cognitive behavioural therapy, counselling, mental health services and things like that. So there is a lot of help available there, but often patients need to come and admit that they're not coping or they're feeling anxious or whatever for us to actually do anything about it. Some treatment pathways are not always appropriate for patients. Say for example, antidepressant tablets have side effects and take a while to work, so if patients get side effects from tablets, they'll stop taking them. So it's important to emphasise what the side effects are. So sometimes they can get dry mouth, headache, feel dizzy, until they actually get used to them. Some antidepressants can cause raised blood pressure as well, so you've got to be really careful when prescribing them. And actually when they're actually weaning them down to stop them, withdrawing them, they can have withdrawal symptoms as well if they withdraw or stop them suddenly. Especially with serotonin inhibitors, they can certainly cause quite a lot of side effects. Some areas of the country still offer ECT treatment, which is electroconvulsive treatment. There is some uncertainties about the treatment of that, really. To me, I find it a bit barbaric, to be honest. It's not available everywhere. Some psychologists will say it does work and some people don't, so I don't think it's widely used at the moment. Some people will actually go out and try and get self-help for themselves, like St John's wort, which is a herbal remedy. Again, that's okay, but we don't recommend it, and GPs try to avoid it, and you certainly should avoid it if you're pregnant. So we don't want pregnant women going buying St John's wort from anywhere. And you can't take it with antidepressants, and that's another thing with it, really. Some people feel uncomfortable about talking about their conditions and the social circumstances, especially in self-help groups. If they're unable to do that, they're not going to be able to make a full recovery. And again, access to these services is often limited. And like I say, self-help groups, people can feel uncomfortable discussing their condition in front of other patients. Patients need to feel motivated to finish the course of treatment that they're given. Exercise, again, may be impossible for some people, especially if they've got disabilities. I always think watchful waiting is often helpful in mild depression, so bringing people back a few times, talking to them is often one of the most beneficial ways. But a lot of these things are unlikely to have any, effectiveness in severe depression. So obviously they need long-term treatment for their depression. They might need cognitive behavioural treatment, which again can be ineffective in some people if they're not motivated. But on the positive note, these things can help. And it's just breaking down those barriers with patients so that they can open up their mind to be able to be helped. And I think that's the key thing of people, nurses and doctors in primary care. That's what we're here to do.
All right, thank you very much.
Thank you.